Hi, everyone, and welcome to the Global P.A.D. Impact Awards, recognizing excellence in peripheral artery disease awareness and education. Our winner for Best P.A.D. Awareness Initiative is Clinic to Community, enhancing quality of life through equitable access in underserved communities. It's led by Natalie Donnally and Dr. Mamdouh Khayat. This program is incredible because it brings critical, you like the word critical, it's critical, brings critical PAD education directly into underserved neighborhoods where traditional healthcare messaging often does fail to reach. Their culturally sensitive approach has significantly increased early detection rates in communities disproportionately affected by PAD and amputation. Through partnerships with community leaders, regular screening events, and targeted educational resources, Clinic to Community has created sustainable infrastructure that continues to save limbs and lives. So please join me in welcoming Natalie Donnally and Dr. Mamdouh Khayat to discuss their groundbreaking work. We are so excited to have you guys here. Congratulations.
Thank you so much. We are so honored and blessed to have received this award for the work that we're doing in the marginalized communities, as you mentioned, Kim. It's been a great collaboration that we have. And as you said earlier, it is critical to have this, just what it's called, an initiative that's bringing the clinic to community. But what's most important specifically for PAD is that we have providers such as Mamdouh and their state-of-the-art practice, Vivascular, that's able to see these patients immediately within 24 hours, right after diagnosis at one of these events. And so having that navigation tool and resource for these patients, of course, increases their improvement quality of life, but also making sure that we are definitely saving their limbs and saving their life within a critical time frame.
Yeah, Dr. Khayat, what does it mean to you to be involved in an organization like this and getting out, reaching out to the community, reaching them where they are, and then guiding them where they
It's
need to be?
yeah, I mean, it truly means the world to me. It's an important endeavor. This is a very difficult endeavor to take on with one group. Physicians can't take it on alone. It's a multifaceted approach. It takes, you know, champions in the community like Natalie that are entrenched in the community that can help navigate these patients. That this is uncharted territory for many. When you talk about the Black community, the lack of knowledge about PAD is 80%. That means 80% of African Americans in our community have never even heard of peripheral artery disease. That number is staggering, and that number needs to be tackled. But it takes a multifaceted, collaborative approach to really work to get this project underway.
And it's really interesting you said about knowledge and lack of knowledge because I just participated, had the honor of participating, thanks to Natalie, in one of her events over in Georgia in partnership, I believe, with Representative Kim Schofield and others.
Yeah,
Um,
that event was
and
with
what,
the South
go ahead.
Fulton City Councilwomen, Dr. Rao and Keosha Bell. And so it took 6 municipalities to come together to make sure that these 6 Black communities in Atlanta had equitable access to the PAD screenings through the US Health Mobile exams, mobile that came, and of course, having a way to my heart there to navigate those patients who had positive results. We had about 18% of those patients who attended that event that were positive and got navigated to the appropriate providers within 24 to 48 hours to make sure that they got the appropriate treatment to lower their risk of amputation August 16th.
What was amazing is that they were all barely even on the verge of intermittent claudications. They were in the early stages, which is the time you really want to catch people because there's so much that they can do conservatively through walking as medicine and diet and some medicine supplementation that they can do to make a difference. But what was interesting at the event is how many people did the test. They said they felt fine and they would go see the doctor and no big deal, but that they had friends and family that had amputations. And I said, well, what was the cause of their amputations? Like, well, now I'm kind of thinking it's their circulation, not their diabetes. And I'm thinking, bing, 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 because 35% of the limbs that we've saved over at the Global P.A.D. Association and the Way to My Heart, they were told initially that their amputation was going to be due to diabetes. And 100% of those that we sent for testing for PAD ended up having PAD. And we were able to save their limbs with an advanced endovascular specialist such as Dr. Khayat. So it's these events are so important because you have to pick up sometimes where the healthcare systems are leaving off.
Mhm.
Yeah, and I think it's important too, and I know that you can attest to be noted that most that got tested were our public servant officers. So we had the police departments, the
Mhm.
firemen. They had no clue about PAD. Again, they associated with diabetes, but PAD can be a standalone comorbidity. But unfortunately, it has been tied so closely to diabetes and cardiovascular disease that those who don't have diabetes or have cardiovascular disease believe that they're exempt from having PAD. So this education and awareness initiative is so important. And this all began 2, 3 years ago, partnering with Johnson and Johnson, one of the largest biopharma organizations here in the United States, where they had a Save Legs, Change Lives initiative. And Mamdouh and I were able to partner closely with the African American Male Wellness Agency, which is a national leading community-based organization alongside Johnson and Johnson and U.S. Health Medical Mobiles, to make sure that we were reaching 5 million individuals to educate them on the awareness of PAD and making sure that they understood that it can be a standalone comorbidity, but also can be tied to the exacerbation of side effects from diabetes, hypertension, and other cardiovascular disease. So we want to make sure that patients understand that just because you don't have diabetes or hypertension and other comorbidities, that you still can have PAD. And even if you're a runner and you're in great shape, you still also can have PAD as well.
And I see right behind you, Dr. Khayat, there you have some imaging from an angiogram. Can you share with us, is that a patient that you have that went through this program?
Yeah, so this patient from 2 weeks ago, actually, with unfortunate
2 weeks.
and unfortunately, this patient had no idea that they were indeed have a history of peripheral artery disease. They have known history of diabetes. They have past history of smoking, and for the long, for a while was just enduring through these symptoms. And initially was an avid golfer, could not golf because of this critical pain that they were having. And it wasn't for until a very astute, collaborative primary care physician said, maybe you should go see a vascular specialist, and sent that patient to us. And lo and behold, had a long segment kind of SFA occlusion that we were able to revascularize in a outpatient procedure that's minimally invasive, all done through a pinhole entry, and open up that artery and reperfuse the entire leg. And thankfully, we'll be seeing this patient in next week in clinic as a follow-up. But I anticipate that this patient will certainly get tremendous benefit from this revascularization, because certainly the lack of blood flow is quite impressive. You don't have to be in healthcare to see the disparity in the two images, the left and the right. And so I think, as you guys eloquently said, catching these patients early with early intervention is critical. I mean, we know the prevalence, the numbers are staggering. 12 million people suffer from peripheral artery disease. 1 in 10 of those individuals, unfortunately, will progress to, critical limb-threatening ischemia, where, their tissue is actually compromised. Their foot, their leg is compromised. And those patients that do progress to amputation, we know that 30% of those with critical limb-threatening ischemia will progress to amputation. The mortality is terrible. I mean, and 50% of patients will die within 5 years after an amputation. So getting these patients early into clinic, having a collaborative approach, both in the community with primary care providers and us as vascular specialists, is key to really tackling this.
So it's great you guys also work with the primary care providers as well through this program to try and help educate them and help them, learn the different stages and the treatment options that are available for these patients, so they don't just say, well, it's just old age, it's just your diabetes. You actually, when they have those little spidey sense that goes up based on what they know now through your organization and your initiatives, they'll say, well, wait a minute, we need to send to Vivascular to have an ABI test or to have an ultrasound performed to check that circulation.
Yeah, and this initiative also takes the weight off of primary care physicians as well by having the collaborative sponsorship as well as relationship with practices like Bivascular, because we're able to do that direct navigation and direct referral directly into their practice. Most of them are out in the streets with us. That is what this initiative is literally being in the streets, doing the education. So having a colleague like Mamdouh that is alongside of us in the streets, doing the interpretation of the ABIs and being able to have their staff present as well in the community to get them scheduled is very critically to the success of this initiative, but also to save lives as well. And again, it decreases that weight of primary care physician appointment wait times, because we know that our PCP groups are just inundated with appointments and they don't have the time. We also know that, we had a brief disruption with the equity lens with our current administration, but we said not on our watch. And so this is why we've continued to push this initiative, just as we did August 16th in Atlanta with city council members of those 6 municipalities, because it's really important to continue doing this work, whether we deem it equity or not. But the whole goal is equitable access and improving the quality of lives of those who have the highest disparity in mortality rates.
And there's still some cultural barriers in that a lot of folks, I've been told, we also still have our own DEI committee that is made up and led by patients. And what they tell us is that there's still long-standing fear of going to the doctor, and they wait and they wait and they wait until it is just, they can't wait anymore and they end up in the emergency room, but they don't do the preventative appointments or the early diagnosis, because also they fear that diagnosis. They don't want to hear something's wrong. They want to hear that they're going to rub a little, lotion on their legs to magnesium oil to get rid of any cramping in their legs. They want to hear that that's the type of thing. If they have cold feet, they just want to hear that putting a heating pad on there is going to work. They don't want to hear that something is really wrong because they fear going to the doctor. They fear that white coat even still.
Absolutely. And that's where we bring in the cultural relevance. So looking like them and being like them, being casual, having that conversation, bringing it down to layman's terms as well, and being cognitive too, that illiteracy is still a great proportionate to why these communities can't grasp the education and awareness. So being cognizant of that and removing those biases to be able to really do great social determinant of health assessments to make sure that we're eradicating those barriers that will then lead them not to get the preventative health care. But we've got great success in bringing this out to eliminate that barrier of coming into the health systems and building those rapports. And so, lowering the race discoordinates as well in this initiative has really increased the participation rate of those that participate and feel more comfortable with us being in their own space, and making it more about them and making them the center. So it's a very patient-centric initiative, and it's done intentionally to make sure that we are lowering that risk of mistrust and the history of not participating in certain healthcare systems. But this is a full spectrum initiative, and that's why it's important to see the collaborative effort. And I know that all of us on this call and many that are watching understand that collaboration increases the impact when they see that health systems, insurance companies, biopharma, primary care providers, specialists, community-based organizations, faith-based organizations are coming together for the benefit of their quality of life, and that makes them feel more comfortable to participate.
I think even as an extension of that, yes, distrust is definitely a hurdle to overcome, and that takes that collaborative approach where we entrench ourselves in the community and gain the trust of these patients. But beyond that, I think accessibility is something that we need to highlight and emphasize, and that is a problem that is entrenched throughout the healthcare system. And so, when you have these hospitals that are very difficult to navigate from one physician to another, it's very easy for patients to get lost. And when they are lost, or they feel that it is very difficult to navigate, it's easy to say, well, I give up. It's too difficult of a process to navigate this and get the proper care. And so
You
when
bring
you
such a good point.
and so when the physician is not only in the community, but in the actual clinic is readily accessible, that someone
Yeah.
can call and come in and walk from the street and walk into our clinic, it makes it that much more easy. And so, the numbers ultimately don't lie. We know that the rate of amputation in the Black community is 3 times that of whites. That's a dramatic disparity, and that has to be overcome. And that's not exclusively as a result of distrust. I think accessibility plays a tremendous role in that. And we need to work hand in hand with collaborative partners like you, Kim, and like Natalie to kind of get those numbers down.
And I think changing the paradigm too of this minimally invasive approach, because
Yeah.
Black and Brown communities have been traumatized by some pretty heavy invasive procedures in the past. And so that's what we love about Bivascular and some of our other partners, is that they're minimally invasive procedures that are available to these patients, and being able to come in and go out the same day and not have the large side effects or the long-term post-operative care is really important. And of course, people talk. And so when they have these minimally invasive procedures and these great outcomes, and they're able to go right back to their daily living and go back to work within 24 to 48 hours, that makes a huge difference in getting the word out in the communities as well. And those patients becoming our new advocates and ambassadors for the education and awareness component to this initiative.
All right, we did a very powerful, which reminds me, maybe this month I should re-air it, because I couldn't believe. I wish I knew you then, Natalie and Dr. Khayat, because we had more than a dozen um, African American patients that showed up for this conversation that was incredibly candid about PAD and the fears of going to the doctors and the stories that they were sharing about their grandparents and great grandparents and the amputations and hey, they had their leg amputated because of their sugar. They had their leg amputated because of the pain caused by their sugar. So if my pain is caused by my sugar, and I'm just going to end up like my ancestor, it's like, my grandfather, my father, grandfather, great grandfather, all of the above, then I'm going to just stay out of the hospital as long as possible, try to stay on my feet and keep my legs intact as long as possible. What they don't realize is nowadays there's so many options, such as what Dr. Khayat offers, that are available, and they don't just need to have their legs cut off. But what's even more disconcerting is when they do show up in the emergency room, more often than not, especially in some of these communities, um, there is still like 30% of hospitals out there are looking for vascular surgeons. So they're short vascular surgeons, and you end up with a general surgeon at that local community hospital that doesn't have any option for them but amputation. And we try, if a family member or the patient calls us and says, "Hey, we're on deck for amputation." We've had situations where we were even able to get on the phone with the general surgeon and go, "You really don't want to cut off their leg, do you? You just don't have any other option, right? And you got to prevent sepsis." And they're like, "Yeah, do you have anyone else?" And we've been able to work with them to facilitate a hospital transfer to a larger tertiary center that might have a limb salvage specialist. I wish we could transfer to an OBL, but it's hospital to hospital, right? And so it's really important for patients to understand all the resources that are available, and the fact that there are options, and to ask the questions. How many times have you heard yes, ma'am, and yes, sir? And you're like, no, ma'am, no, sir, no amputation. And so many at that point, they don't trust the doctor. That's why they're not going. But then they get there and they're like, well, I just have to trust the doctor. And it seems, yeah, and I think that latter end is simply because, well, my whole family's had amputations, so it just is what it is.
And I think with this initiative, that's what we're able to show, just having the mobiles as well. So partnering with US Health Medical Exam mobiles, they bring the ABI mobile to everywhere that we are, and understanding that, again, that's a non-invasive Doppler. You connect the blood pressure cuffs, you do the ultrasound, and you have
Yeah.
your answers. You don't even have to get undressed to get the answer. And so that has changed drastically how people feel about getting those exams. But that's what is really key, is having the mobile accessibility and bringing it directly into the streets of where people live, to give them that opportunity to learn and understand what's best. And that's one thing we love about Bivascular, is they're not just a clinic, they have a surgical center here as well, post-operative, and they're able to have the education. But what's also most important is working with a patient navigator consortium, because they're able to not only navigate quickly, but also do those social determinant of health assessments, because we know we can bring in any patient, but if they have any of the social determinant of health barriers, they're going to be more focused on that than their own health. And so having this full spectrum initiative assesses the social determinant of health barriers, but also the disparity in mortality rates of those that we're serving. And then we have a great continuity of care portion to that. So it's a full circle initiative to where they get the preventative health screening, the education awareness, the navigation, the eradication of their barriers, and then the continuity of care with providers such as Dr. Khayat and other providers we work with.
And I think that's the
Yeah.
key, is that
Go ahead.
continuity of care. And so, unfortunately, far too often a patient will come see a vascular specialist and not see a vascular specialist for 5 to 6 years. Ultimately, in a patient that has risk factors for vascular disease, the way they have a heart doctor, the way they have a diabetes doctor, in theory, they should have a vascular doctor that readily checks on them annually, makes sure that their numbers are good, and they're taking care of their health. And not every patient that comes into our office with claudication gets a procedure. We emphasize the conservative endeavors that have to be taken to kind of get these patients to feel better and to get better. And so, but that's the importance of continuity of care.
Yeah, and I love that, I love working with you guys, because you guys get that in working with us, and we continue. When you can't be there, when it's beyond the clinic, when it's beyond the diagnosis, beyond, they can call our Lifesaver hotline, and they can get a person, they can get a human that is not just looking to get you off the phone as quickly as possible, navigate you to where you need to be, and then move on. We actually can sit on the phone with them. And you talked about the illiteracy. I do not like the word uneducated. I love that you are one of the few that is out there that just uses illiteracy. That's the issue, because they're smart people. I talk to them and they get it. They're like, why doesn't anyone just talk to me? Why do they tell me that my veins are blocked when it's really my arteries? Like, why do I have to come to you to understand what the SFA is? Yeah, that's your thigh. Why do I not get this advanced education? And why do you not teach me the mechanism of action by which smoking does damage to my arteries? Don't just tell me don't smoke. We know we're not supposed to smoke, but I need to get the picture, paint the picture for me, doctor. And so that's when they come to us, and they're able to also have us call the doctor with them, do telemedicine visits with them. They can also have us help make the appointments for them, remind them of their appointments. And then, also the lifestyle modification support, that we can partner with all of you guys and the doctors um, to help beyond with those incredible risk factors.
Yeah, advocacy is so important in improved quality of life, because, like you said, they are educated. It's just that they haven't been exposed to the right information. And we have so many
Yeah.
myths that are out there still to this day, or we have so many particular populations that are holding on to the historical mistrust that has happened. And so we're able to kind of reverse that and talk through
Yeah.
that. Even we haven't even touched base on research, but this clinic to community has a pragmatic research component as well. And so we're able to enroll more Black and Brown populations into clinical trials and pragmatic researches, because we know that 98% of modalities are driven for the Caucasian or counterparts. And so the efficacy rate is lower anyway when it comes to those treatment modalities for the Black and Brown communities. So
Mhm.
having the enhanced enrollment in the clinical trials and pragmatic studies within this initiative also improves new treatment modalities, but also exposes the minimally invasive modalities that are done right here at Bivascular. And so we're really excited to be able to implement that in this initiative as well.
Yeah, let us know. We'll put whatever trials that you have on our padtrials.org, and which maps the trials. We're trying to map the trials across the globe, but then we can do videos to promote each individual one in the communities that you want, and whatever we can do to support you with that. That's such a brilliant initiative. Amazing. And I'm curious from your perspective, I mean, is there a website people can go to learn about, these things, learn about more about what you're doing to get involved with what you're doing and to find out when your next community clinic is organized?
Yeah, so we definitely have Bivascular's website that has great education information on PAD, the minimally invasive procedures, even non-invasive treatment options that are there. The OSU website, Ohio State University Wexner Medical website, will have information. My LinkedIn page has the information as well because I partner mainly with government entities as they're starting to enhance their equity implementation in their communities, to be more prominent, to build on the equity initiatives that they have specifically in health equity when they're serving more Black and Brown communities in their cities and area. And then the advocacy components too. So all of our partners, the Johnson & Johnson My Health Can't Wait campaign as well, is another resource that has numbers and numbers of education and awareness on the
I love them.
myhealthcare.com
Yeah.
page as well. So
They do a great job with their educational materials. Very simple, but yet they don't talk down to you.
Mhm.
They really talk to you. It's pretty awesome. And do you have anything coming up, or are we, a little bit of a time out, as we head into the fall and the winter here?
we're at a wraps for 2025, but we do have some exciting things happening. I'll be transitioning as well in the year to come, so there'll be announcements about that. So I'm really excited, but we will make sure that we connect with the weight of my heart, to make sure that we can keep promoting what's happening in the communities, the advocacy component. Like I said, advocacy is so important. And when we talk about the illiteracy, I'll never forget a patient that we had in Memphis, Tennessee, who was sitting on a stone wall, just swinging his legs, minding his own business. And this is how this initiative makes you so in tune to the community, is that I was able to go over and I saw him with the clipboard with the assessment sheet. And he said, oh, I was just waiting. I don't know how to read. So I was just waiting for somebody to approach me to fill out this form because it's really important for me to take control of my health, but I didn't want to overstep and not follow the process of completing
Oh,
this form. So having that experience again just goes to show how important this is to be directly in the community, have the advocates that are so vital in these communities to continue that continuity of care and make sure that everyone has access to what's important across the spectrum of comorbidities to cancer, to education and awareness.
and I remember when we were in Georgia, you told me the story of a patient. There was one that stood out that you got tested and was in serious CLI, and I mean, if he didn't go through your clinic, uh, he probably would have ended up with an amputation. Would you share that story if you can recall which one it was? It was one that stood out to you.
Yeah, absolutely. Again, it was an older African American gentleman who had been a past police officer, had been a runner, thought that his legs were only aching because he had ran too much on certain days, and had taken on gardening and some other hobbies after he retired from the police force. And so was attributing that to just being on his legs all day. Also
Mm.
too, we had the conversation, and this happens a lot, is that men specifically think that PAD is a women's disease because they associate it with varicose veins, not realizing that varicose veins have nothing to do with PAD. And so they don't even think twice that PAD can affect them. So that was the conversation with this gentleman, is that he associated it with varicose veins. His wife had had varicose vein procedures. And so again, he just kept attributing the stress and the aching of his legs to being on his legs all day, running, cycling, and his new hobbies. And so when he found out that he indeed had peripheral artery disease and the seriousness of claudication and what could have happened had he not been tested. And he was someone that I had to keep reapproaching the day of, which happens a lot too. And he finally had it and was so glad that he was able to have the minimally invasive procedure and saved his legs.
That's just an incredible story. And I'm just curious, Dr. Khayat, because I'm hearing it all the time. And we have the discussion. I think that there's a misunderstanding of what PAD is today. And there are organizations that are all about, oh, well, you just need to move and you'll be fine. And it's all about just moving. And it's not about moving, it's about actually moving strategically when it comes to PAD, because I can't tell you how many runners, marathon runners, um, professional cyclists have all come to me and said, I don't know where this came from because I exercise all the time. And it's not until they get into a strategic walking program, get on the right medications, some of them needing a procedure because they end up in such advanced stages, to what you described, Natalie, kind of pushing, brushing it off as, just part of whatever they're doing, overdoing it. And they've ended up so much better. They're like, I didn't realize there was a certain way to walk. I mean, when I felt the cramping, I would just, stop. And I thought it was just, I didn't want to get an injury and I didn't want to push into dysfunction. And so I'm seeing more and more of this, which I find interesting. And I don't know if it's because of the diabetes epidemic that we're really seeing the majority of this, that even if they're active, even if they're moving, that they're ending up with peripheral artery disease. What are your thoughts on this new wave of disease that just doesn't fit in that mold from the traditional textbooks?
Yeah, I mean, when it comes to peripheral artery disease, the misconceptions are unfortunately rampant. The true understanding of it is, it's an evolving endeavor to understand the pathophysiology. We know the primary contributors, be it diabetes, smoking, high blood pressure, high cholesterol, genetics, and then some of the other modifiable risk factors like, lack of exercise. And then, when you factor that into 1 in 3 patients that should be on a statin or antiplatelet medications are not on those medications. When you factor in 70 to 80% of the population have no knowledge of peripheral artery disease, that is a terrible recipe with a far worse outcome. And so, my role as a provider is not to guide a patient to a procedure. My role as a provider is to empower patients by educating them to make informed decisions about their health and take ownership of their health to kind of
Yeah.
better their health. That's the ultimate goal here. And it ultimately does take this collaborative approach. And, kudos to Natalie, kudos to you for taking on this initiative because, direct to the patient, letting them be informed of this is exceedingly better than them coming into an office and learning about it just from a provider alone, so.
I love that here in the US, it's a big deal that it's easier to get referred to a vascular doctor, someone that has the knowledge. We work across the globe, and it's interesting. We have the NHS that a lot of times they don't get, if they don't meet a certain criteria, they don't get transferred to the actual vascular to have the conversation. It's only if they reach a certain stage where they're thought to potentially need a procedure that they're then at the vascular. If the vascular decides that they don't need a procedure, they're discharged. And I think that's the worst thing that you can do for these patients is, one, leave them in the hands of their primary care that have so much going on and don't have advanced education in the mechanism of action by which all of these lifestyle modifications work. They just say, go do them, be compliant, and good luck to you. If your toe starts turning black, well, then give us a call. And that's very frustrating. And that's starting to change. somewhat there. But at least here, people need to know they can get referred earlier on to a vascular doctor, even a vascular NP or a vascular PA, that can provide them with advanced education that can really help them understand the disease so that they can take action and become the best partner in their care.
Absolutely. And, as an extension of this, no two providers are the same. And
Right.
so to go back to our conversation of empowerment, patients should be empowered that if they initially, encounter obstructions to, better their care, be it a procedure that can open up arteries, seek out a second opinion, find a vascular specialist that is comfortable doing these minimally invasive interventions to salvage tissue, because not all providers are created equal.
And this too is why this initiative collaborates with payers as well as government leaders, because we're able also to show the payers that those getting to the certain x-rays to CAT scans to ABIs before you can even get referred to a vascular surgeon. Sometimes not everybody is clinical textbook. And so it's really important that we have the flexibility to make sure that those patients who don't meet those clinical textbook having to go from one modality to the next in order to get to the right vascular surgeon is important. And so having that collaboration with payers has really opened the eyes to them to understand that they're now taking away certain prior authorizations or certain clinical indicators that have to happen before they're able to get referred or services are paid for either the non-invasive or the minimally invasive treatment options. But then secondly, having the government leaders right alongside of us as well, because they're able to help us in DC and push House bills that make things, prominent in that space for our constituents and patients that we're treating, to not have to go through those certain barriers to get to a vascular surgeon quickly. And this initiative is highlighting that, and it's highlighting the importance of working right alongside providers like Dr. Khayat, who is able to get the patients in within 24 hours. There's many days and nights I can text him and I said, hey, we got a patient. And I know, Kim, you do this as well. We're able to reach out to those providers. We get the patients in quickly, and that makes a huge difference in the patient's trust factor, but also that they feel important and they feel control into their treatment plan, and that they were important enough to have that quick of a turnaround and getting diagnosed appropriately in enough time, and then having the appropriate treatment to save their limbs.
Oh, and not have all the anxiety. I mean, the biggest thing with these patients when they call is they're like, I am so stressed out there. And what does stress do, Dr. Khayat? It adds to the problem, right? It adds more inflammation to your arteries, which is the ultimate attractor for more plaque. So it's nice to have that quick turnaround so they can, get the diagnosis and then have the discussion. It's so incredibly important. And I have to say that because we haven't talked about it, we did put out the promotion for it, but because of your event in Georgia, representative with the Georgia House of Representatives, Representative Kim Schofield, has agreed to do a resolution for P.A.D Awareness Month for the state of Georgia, which I think is huge. But it was because of what she learned. I remember when she came up to us at the event and she learned so much about P.A.D that she was like, let's do this.
Mhm.
Let's raise even more awareness so that people get earlier testing and earlier treatment. So that's definitely because of you, Natalie, and what you've done.
Well, thank you. And that's also how we were able to get the six municipalities in Georgia, is that those councilwomen attended the Congressional Black Caucus, where we had the Johnson and Johnson Pavilion, and we had U.S. Health Mobile Exams Mobile doing the ABIs right there. So they participated in their own ABI screening, and of course got those results. And having the awareness and education and seeing the impact of those that were getting screened. And then when we shared the positive result percentage, again, which was at 28% of those who got screened, they knew that it was going to be impactful and important to bring that to the city of South Fulton and College Park areas, to have that. And as you were able to witness, Kim, we had the firefighter. I don't know if you remember.
Yeah, I remember him.
had to keep coaxing him to come over. And finally, he came over, but he wasn't coming over again because of the fear of the family members that he shared with you that had already gone through amputation. Some had a diagnosis of diabetes, others didn't. So it was a little confusing as to this being correlated with having diabetes, but then the family members who didn't have diabetes, why did they have PAD? But having them come over. And I think that that was a great event to show that our public service officers who deal with astronomical stress have the
Yep.
highest rates of hypertension crisis, as well as PAD and other comorbidities, just from the stress factor of their jobs day to day in. So I was really happy to see how many of those police officers, firefighters, and EMS actually came over to get their PAD screening and had the opportunity to learn more through a Way to My Heart organization that was on
Uh,
site.
Because they're also, it's going to be like diaspora when they're out there, especially the EMT guys, when they're out there with these people that they're picking up, they can go, oh, I know what this is, and talk to the patient about, PAD and the resources that are available. And I thought that was incredible as well. But we do have a live YouTube audience right now over at youtube.com/, the at sign, the way to my heart. We have Marie who is chiming in. She gave me a nice little compliment. Thank you, Marie. But she is asking, what is the best to help with when your legs feel like they are weighted down? Is there some way to ease it some? I know that's a loaded question because it could be arteries, it could be vascular, it could be lower back. What are your thoughts to help her disseminate between which it might be, which direction to go, and maybe some thoughts on how you advise patients on easing their symptoms?
No, absolutely. I think it's starting out, if she has a primary care provider that she's built a relationship with, making contact with that primary care provider will be able to perform a physical exam, get a proper history, and help that patient navigate to the proper specialty provider that they can then further evaluate. When it comes to leg symptoms, as you kind of alluded to, it can be multifactorial. There's a lot of pathologies that can manifest as leg heaviness or leg pain and discomfort, be it venous disease, arterial disease, overall vascular disease or non-vascular disease. So, I think it just starts with that initial encounter with the primary care provider, proper assessment, proper history, and then navigating from there. And it may be a kind of a slow process of checking off various boxes until we get to the proper diagnosis. But it starts that with that primary care provider.
I know with my dad, that heavy leg feeling, gosh, we went through so many different things. We went through um, doing checking his arteries, wasn't his arteries. We ended up checking his veins for chronic venous insufficiency. He did have some of that. He had 4 venous seals to seal off a little super glue in those troublesome veins. That did nothing, made things a little bit worse. We went to another vascular surgeon, actually flew him to Houston, Texas. You might be familiar with Dr. Miguel Montero Baker with Hope Vascular there.
Mhm.
And I sicked him on my dad
Yeah.
and ended up with taking Venexa,
Mhm.
which is like Vasculera, which eased it a lot. He got the extra swelling down, which shocked the heck out of me because I had never heard it before. And when you look up Venexa on Amazon, at first it was only coming up as a hemorrhoid medication, but then you do a little bit more research and find out it's for chronic venous insufficiency and edema, and there's also vasculera. But then fast forward, okay, so that eased it some, but then there was still additional issues, and it turns out that the rest of it was more from stenosis in his back. So
Yeah.
as you said, it could be a little bit of everything, and you just have to dissect it one by one by one.
Right. Absolutely. And and a lot of patients, unfortunately, we encounter this often where they've met so many providers and it's exhaustive. But don't lose hope. Keep
Yep.
asking, and eventually you'll get to someone that you have built a rapport with, that you trust what they tell you, and hopefully guide you to a proper diagnosis and treatment.
Yeah, she says she has advanced in both artery and venous. I think that for Marie, they focused mostly on the arteries, and I think that they haven't focused enough on the veins as well. And I do think that there is a greater focus these days on the veins. I think there are more and more doctors that are focusing beyond the varicose veins and looking deeper. Um, but I still think in some areas, such as in hers, they're like, "Oh, you have something wrong with your veins. We just leave it alone," versus kind of addressing the issue. But that's important when you have artery issues, right? And you have lack of blood flow or sluggish flow, that can affect your veins as well.
Yeah, and
Because if you
it's
don't have,
no,
go
absolutely,
ahead.
and it's important not to get lost with satisfaction of search, right? You come with your
Yeah.
first diagnosis. Patients are diagnosed with neuropathy, and or they're told they have sciatica, and that's it. No further investigation beyond that, and then you do further investigation, you find out they do have vascular compromise. So it's important to make sure that we exclude all pathologies.
Okay, we have 10 minutes left here. So I'm going to do our speed round. This is where we love for you to share your stories. It can be any story that you might have. It airs, we segment these into multiple sponsored segments that help spread additional awareness about PAD and also create additional discussions based on whatever the topic is. The first question, you can choose who goes first and who goes second, but since Natalie is also a PA, which we didn't really talk about, and she has a lot of really great stories um, that I know. Um, I do want to include you in all of these because I'm sure it's not just the doctor that's got these stories. So, first one, describe a case that you learned a lesson from that other physicians or clinicians can learn from. It could have been a success, it could have been a failure. We've had both.
Yeah, I think I think where it's, when it comes to cases that you learn from, and you can kind of layer this into two aspects, right? There's the scientific learning where you kind of encounter a pathology that is unbeknownst to you, or you're kind of learning about, or something that kind of alters your perspective on a pathology. For me, the latter is more eye-opening. For example, when it comes to peripheral artery disease, we're often focused on the patient exclusively. We're focused on making sure that the patient can walk. We're making sure that the patient has proper circulation, that their foot is not compromised for potential amputation. But we don't see the ramifications on the entirety of the family and everyone that's under that same roof. A patient that is unable to sleep because of rest pain, and then throughout the day is a little bit more irritable because of their pain, their lack of sleep, or a patient that, is unfortunately can't travel due to the long flight and the long walking, extensive walking that would and then missing a normal annual family trip. That's tremendous ramifications on the entirety of the family and all the work that is involved with taking care of that patient. God forbid they have a wound. And so for me, there's, that's certainly an eye-opening component to when we're so focused on the pathology, we're so focused on the patient, but we tend to forget the family that suffers as a result of it as well.
Yeah.
When we take care of the patient, the family certainly benefits from it tremendously. I mean, just a month ago, I had a patient that had severe claudication, to 20 yards, no more, and that patient's claudication would come on, it would force him to walk with a cane. Intermittently, he'd have cramping at night, couldn't sleep, and the wife, they've been married for 40 years. She told me that, I feel like I have my husband back. To me, that is profound, right? And so yes, he's able to walk. He's no longer using the cane. He's ecstatic about the outcome. But the wife of 40 years says, I have my husband back. And to me, that speaks wonders.
Yeah, and I think into that too, this is why we don't do this initiative without patient navigators and community health workers, because they're able to assess those family contributors that Dr. Khayat is speaking about and bring that to the provider's attention. And so we're able to listen to understand better. And I think that that is a missing component when we're rushing or we're overcompensated with patient loads is that we don't listen to understand really what's going on and is contributing to the stress. I know another factor is a lot of patients think that they can go and get Job stockings and fix the diagnosis of PAD. And that's something that we don't talk about a lot as well, but you can actually make things worse because those are prescriptive as well, even though they're over the counter, but just making sure that you talk with your doctor about what stockings are best for you, and your treatment plan in that as well. But having those components, and that's why this initiative is a full spectrum of multifaceted providers and caretakers and advocates to make sure that we're honing in on each component that affects this patient negatively, to really increase and enhance the quality of life overall in those that are living and part of their support team as well.
Do you want to add another case? Do you want to describe a case that you learned a lesson from, or leave it where we are on that one?
Think we can leave it where we are on that one. I think, again, it just really comes down to being holistic in your approach. And sometimes we miss that piece. And that's why this initiative is so important, because we can't necessarily have this initiative in a hospital setting or a clinic setting 100% all the time, because of different dynamics, whether it's bureaucratic, whether it's insurance driven. There's different components, also depending on the care team, as well. I know at OSU, we have a couple pilot studies that are zoning in on different divisions that are really utilizing the multifaceted approach and have been trained to do social determinant of health assessments, which have really decrease the readmission rates, and obviously patients not having certain barriers eradicated. And so I think as we continue to see those results in the pilots and the research studies that we're doing, and having this type of initiative in the hospital setting as well as in the community and other areas, but increasing the advocacy component as well with organizations such as yours, Kim, and other community-based organizations, that this will make a drastic shift in the paradigm of how we approach and the success rates that will continue to rise with saving lives.
I love this next question because I think through clinic to community, you're going to have quite a few of these. Describe a case where a patient should have been diagnosed with PAD sooner, but wasn't, and because of that, presented on deck for complex revascularization or amputation. And this is really to raise awareness of the delays in patients seeking care due to a variety of their own reasons, and or doctors brushing off their symptoms as old age or diabetic neuropathy or diabetes or back issues or whatever it might be. And so they end up with a misdiagnosis because of it. So which case really stands out and just has you shaking your head? How in the world?
Hmm. I I can go, and I had a patient that actually came to me from a colorectal surgeon. So I'm an interventional radiologist. My partner, Dr. Mamdouh, is a vascular surgeon. So between us, there's a lot of pathology that we cover. And so she came to me from for evaluation of her bleeding internal hemorrhoids. She had pronounced hematochezia or bleeding with every bowel movement. It filled the entirety of the bowl. And she had a lot of comorbidities that prevented her from having a hemorrhoidectomy, or tolerating even anesthesia, for the most part. So patient was sent to me for treatment of internal hemorrhoids, and we did a colonoscopy. We confirmed the internal hemorrhoids that were bleeding, and they're pretty sizable. And so we evaluated her and she elected to proceed with hemorrhoid artery embolization, which is a minimally invasive procedure to target and treat internal hemorrhoids from the inside endovascularly. She went for the procedure, and all along, she's so proud of herself because she is despite her age, and despite her comorbidities, she was an avid weightlifter. She enjoyed weightlifting at her age of 70 years young, and that was one thing she took pride in, working with her husband at the gym. But she said, I work out until my sciatica kicks in, and she was focused on her sciatica, and that's a fault on me that I was kind of focused on her internal hemorrhoids, that I just kind of let it go that she has some back issues. She said she has a history of back surgery, and I left it at the sciatica. Um, and so proceeded to do the procedure, and for that hemorrhoid artery embolization, I have to cannulate an inferior mesenteric artery that arises from the aorta directly. And so just with the wire advancement, noticed immediately that this was going to be an exceedingly more difficult procedure than I anticipated. And sure enough, her sciatica was not related to nerve impaction or nerve injury from her back. It was truly due to arterio-occlusive disease, as both of her her common iliac arteries were occluded. And so, was able to kind of treat her and navigate her obstructions to at least treat her internal hemorrhoids, and then bring her back to treat her iliacs. And so, and in her case, with how severe the blockages are, she was brought back in for endovascular intervention to try to, after treating her hemorrhoids, brought her back in to treat her bilateral common iliac occlusions. And it was a boulder, it was a rock. Tried every tool that I have at my disposal to kind of get across. And, it's too far gone. Her obstructions are unfortunately too far gone. And they kind of were pretty extensive. Not only did they involve the common iliacs, but extended to the external iliac as well. And so one of the sides, that I was unable to get across, now we're evaluating her for a bypass, and thankfully I have my colleague, Dr. Madhva, to evaluate her for that. He's a vascular surgeon, but it speaks to, finding these patients early, and identifying the pathology, because if she indeed was identified earlier, no doubt, I think she would have avoided a major surgery like a bypass at her age. So no, that's
And I think, and this was a case that we shared at a dinner that we had for colleagues that Dr. Khayat and Mamdouh led just a couple months ago. And so I think continually bringing these case studies to the forefront with other colleagues will start minimalizing the misdiagnosis or the length of time that it goes to get these patients to a physician like Dr. Khayat or Dr. Mamdouh to have the appropriate treatment and having the education. Kim, you do a phenomenal job having different case studies that are highlighted on all of your social media platforms, LinkedIn, and having the videos and collaboratively working with providers who are able to have these case studies. I know that Vivascular, I'm always looking at their LinkedIn page, even when they come into these complicated circumstances, they're working within their colleague network to say, hey, have you had this case? What works for you? What has worked for these patients that have had these diagnoses? And I think that that's what's important. And I think this initiative has highlighted that as well, is that as we continue to grow our provider network in collaboration, providers are able to feed off of one another, to talk about these complicated cases and see how do we navigate and how do we work with advocacy groups like A Way to My Heart or community-based organizations, faith-based organizations that have medical teams, to be able to continue talking through these difficult cases to enhance the life of those that have the complications that have unfortunately gone way too long without treatment.
Yeah. Do you have another case that you want to share? Do you have any other cases that Natalie, you individually want to share on that one?
I don't think so. I think a lot of mine is really just connecting with the patient and making it comfortable for patients to want to get screened. So many patients still just don't feel comfortable. And sometimes, too, even in the community setting, even on the medical mobiles, they still feel a little iffy. But it really comes down to relationship and how you communicate and connect. And so sometimes you've got to be there for a half an hour, 45 minutes, or know when to revisit. And so out in the community, we'll, kind of let them, talk to other patients that are there or have gone through the screening that they're kind of iffy about. But having ambassadors is really important as well in the community. So we use a lot of the Divine Nine fraternities and sororities that are able to get the information out as well, and working with those that have had great success, but also some that didn't have great success until they were participating in an initiative like this. And so having that conversation eases the comfortability of finally getting that screening that's going to save their life.
Undoubtedly. Undoubtedly, the work that Natalie does is far and exceedingly more impactful than the work that I do. I'm just a glorified plumber, nothing more. She's doing you need to get these patients to the proper care that they need.
I think everyone has the most amazing role, but I love what Natalie, I mean, I feel grateful to be a part of it, and to be chosen to be a part of it. So, and I appreciate you letting us feature this because I think that more people need to know what you're doing and the impact that you're having, and to bring you in to partner to do more of these types of initiatives. This one's kind of a weird one. I'm not sure, Natalie, if you have a story, but Dr. Khayat, I think you might about share a story of a patient who impressed you with their effort to improve their PAD prognosis through their own perseverance. It could also be one who's doing it in partnership or did it in partnership with you and because of your inspiration. We had a doctor, I'll give you an example, Dr. Vincent Rowe from UCLA, who shared the story of a patient on deck for amputation. And she got into what's known as grounding and was going, doing grass and she was doing sand. And then she got a grounding pad. And he said, more than a year later, she still has her legs and she's walking further and faster and doing great. And so he's like, I don't have any clinical evidence on that except for this one patient and I see it works. So maybe you have a story of a patient like that.
I've
But
had plenty of patients that come with their own remedies, be it olive oil, honey, and I don't knock it. If it works, do it. And so, but I will speak about the importance of working with these patients to modifying their own risk factors. A patient comes to mind immediately that very pleasant elderly woman with breast pain and bilateral lower extremities. She's endured a lot in her life, be it the death of her husband and the death of her daughter. And so, smoking for her was a coping mechanism. And so, I didn't want to, she tried and tried to quit smoking and just couldn't. But, I did the revascularization and we got resolution of her rest pain. Unfortunately, all for the work that I did to kind of regress, and her symptoms came back within 3 months. And then, had a deep heart to heart with her and gave her some tough love, but also nurturing love, and told her that, this is something that she needs to take the initiative with, because there's only so much that I could do. And she did the hard work, and she called me even before her scheduled re-procedure. She called me and told the entire clinic that she had stopped smoking, and she was ecstatic. And to this day, I saw her for a 3-month follow-up. She's still not smoking. Her symptoms have resolved. And so, stories like that mean a lot to me, because it's more than the procedure. It's beyond the procedure. It's empowering these patients to alter their lives, to take control of their lives despite the hardships that they've encountered day to day, and really better their health.
I think that's the best part of this, and being a provider, is that I still get text messages from patients who have success stories. And it's the funniest thing, of different types of pictures, on beaches or in particular boots or things like that. And I think that's what really makes this so rewarding, is that you're able to allow someone to empower, to take control of their own health and understand that their health is vitally important. Even when I worked in hospice before, we had patient after patient who would come in and say, I watched my loved one die this way and I didn't want to be in that position, but here you are in that position. And so empowering them to be able to take control of their life much sooner, so that they don't have to live, and their loved ones don't have to watch them in that state. And so I think that's what's most rewarding, is getting the connection and then watching them flourish in the
Mhm.
excitement that they were able to reverse a lifestyle change that was contributing to their mortality, really, and the disparity rates of them being in that percentage. And so if we just save one patient, we're all about quality, not quantity. And while we see thousands and thousands of patients in these events, it's all about that one person that you're able to change in a 360, and empower them to want to have a new quality of life. And then it trickles down in the family. And sometimes we even start with the kids, because the kids are able to then share how important it is for them to have their parents and grandparents for longer than what they expect, based on the generational cycles of those that have the genetic predispositions of these diseases. And so that's what makes it rewarding and such a blessing at the end of the day.
Okay, your best motivational speech for walking is medicine. It could be an analogy that you use. How do you motivate someone to walk, walk, walk and grow their natural bypasses?
I've used a lot, some tough love, some more comforting. When it comes to walking and exercise, I tell them to, especially if they have loved ones, they come with their loved ones to the office, and oftentimes they bring their grandchildren. I said, look at your grandchildren. Let that be your inspiration. You want them, you want to see them prosper. You want to be able to partake in key events in their lives. Use that as your motivation. And so, to me, that oftentimes encourages them. And then I tell them that, it starts with small incremental steps. I think a lot of it to patients is daunting. The idea of exercising or walking extended period of time is daunting, or they don't know how to start. I took it upon myself when I started at Vive Vascular to build a kind of a walking program that we have on our website that patients can access, and it takes them kind of day by day, week by week, incrementally to increase the distance and the time that they exercise from mild to moderate to kind of incrementally heavy exercise. And I tell them, even if it's 10 minutes, start there and kind of slowly build that motivation. When it comes to other smoking, I'm a little bit harder on them, but each person, and you got to read the room. You got to understand how patients respond, what motivates them, and
Yeah.
that's in that 30-minute encounter, you got to learn that patient to where what motivates them and use that to your advantage to kind of get them to take ownership of their lives.
Yeah,
You know,
relationships
you
are so
oh, go
important.
ahead.
Relationships are just vitally important to having success in their progression. And so I think each patient is different, because you connect with them different on different things. And sometimes that connection can take a few times, but you find that one thing that that you can relate with that patient, and then you're able to then kind of give that tough love that is received in a different manner and is received well, and they run out and they flourish, and being successful in taking control of their lifestyle changes.
And I think, Dr. Khayat, I don't think I've ever approached you about our walking program. Our walking program would actually just match with what you're doing. You give them the directives and you can actually get the dashboard and see what they're doing. It's free. So
I'll
it
have
would just,
tell my patients about it too. Absolutely. Another resource. There's so many resources, but the more the merrier. Absolutely.
yeah. Well, it would just be coupled with your program. You have your program and this is just used to track it. That's
Right.
all it is. But
That's
it
right.
tracks the claudication time as part of it, so it's different than
Even
a
better.
regular
Even better.
Fitbit. But
Yeah.
um, and it also has a symptom tracker, which helps you as well. Um, okay, so two more quick ones. This is share a defining moment, and I'm curious. I would love you, Natalie, to um, make this as part of the clinic to community because I don't think we ever really talked about what was that defining moment for you in your career when you said this is really what I want to do. I want to help people with PAD especially, and especially in these most vulnerable communities. Was it a conversation you had, something you saw, um, a patient you were helping?
Well, it's in my DNA, unfortunately. So it's all I know. As you're aware, my grandmother, Kathleen Henry, just passed away at 105 on August 11th, right before our Atlanta event. And so I grew up only knowing to give back and help underserved communities. And so it's been in my DNA to do this, but going into healthcare, I started out in hyperbaric medicine and then transitioned into surgery, and then got into transplant and tissue procurement as well. But working with phenomenal colleagues, and understanding really what was lacking, and having the conversations. I've always been a relationship builder. And so having those relationship conversations with patient and really listening to understand what the barriers were, really fueled the passion that was already inside of me to continue doing what I needed to do to make sure that we had the right initiative, to help these different communities that had all of these barriers. So having phenomenal colleagues and senior leaders and partners has really been key to developing this. This was a co-collaborative built initiative, at OSU, and we utilized it, working with the African American Male Wellness Agency, being the leading national community-based organization to do the recruitment and enrollment, but then also to working with biopharma and clinical trials, and seeing the disparity, in even not having the right efficacy of modalities for these patients. And so when I saw the effects firsthand, I knew that I had to continue pushing forward, to make sure that I did my part and collaborated with colleagues. So I have one colleague in, specifically Lolita Davis. She's a clinical nurse specialist as well. And her and I really were in the trenches with the faith-based organizations pre, during, and post-COVID as well, doing vaccine clinics. And so this kind of highlighted the need of collaboration with major healthcare organizations here in the city. And
Yeah.
then, of course, it was a ripple effect. And so partnering with the African American Male Wellness Agency, organizations such as Johnson and Johnson with their My Health Can't Wait, they were able to push it out as well. And so when other partners, began to see the ripple effect, then they started joining us to build, the collaborative effort that we have. So we have a consortium of over 400 providers, social care, networks, as well as patient navigators, community health workers. And then the government entities started seeing the impact and the payers started seeing the impact. And so everybody started, chipping in to make sure that they had a part in that. And they weren't just doing it to check a box. They were doing it because it was important. Equity is important. And so that's also why I do the policy work that I do with our state legislators, Congresswoman Joyce Beatty, and local leaders, to make sure that we have what we need in place to keep pushing forward, the equity, need that is needed for these communities. So I think it will always be, an overwhelming passion for me, and I won't stop until, probably I take my last breath, but, that's what's important for me.
For you, Dr. Khayat, what was the most defining moment in your career?
Meeting me.
Yeah. There's before Natalie and after Natalie. No, so, it's for me, I've always been inspired by, cardiovascular work. Be it cardiovascular disease, renal disease, smoking, diabetes, I can identify individuals in my family that have all of the above. And so, all the stories that I hear patient to patient, even as in medical school, I remember hearing these stories. And at the same time, I'm entertaining phone calls from families abroad about various pathologies that I'm seeing day to day. That motivated me more to be in a specialty that has tremendous diversity, where I can treat multiple pathologies and be heavily involved in that. And that led me to interventional radiology as my specialty. And then when you start learning, and I enjoy history, so when you start learning about, Dr. Charles Daughter is the father of interventional radiology, and the work that he did, and the first procedure, endovascular procedure that he did on a patient that was able to salvage her leg. She was told that she could only get an amputation, and he ultimately saved her leg with the first endovascular procedure done, first angioplasty done on a patient. And her famous quote was, I before she died, she said, at least I'm walking on my own 2 feet. And so that to me, certainly carries weight. And I hope to, continue to help patients the way that I would certainly want people to help my own family members that are enduring a lot of this pathology.
And I think his cultural relevance too has really given him the autonomy to have great bedside manner. And so patients are able to connect with him directly. Even Dr. Manova, the same thing. Like they're just really able to intimately connect with them. And when you have that intimate connection, then obviously the trust is 100%. And so you're able to then push forward and give them the best options to make the best informed decision for themselves. And I think that's why I like working alongside of him so well, is that he really is in tune to how important cultural relevance and sensitivity
Yeah.
is when dealing with these patient populations.
And I have the last one is the fun one. Just goofy. Got to end on a really, really light note. After all of our heaviness and deep thought. Um, a moment with a patient that still has you shaking your head. Something that patients can learn from, mistakes patients make. It can even be a, I can't believe a PAD patient just did that, or I can't believe they just said that. Um, I have had literally a diabetic PAD patient staple their socks up.
Wow. For me, it goes back to,
Don't do that, by the way, just
yeah,
FYI.
that's
Don't
it.
try that at home.
Yeah.
Yes.
Yeah. I remember my first vascular surgery rotations in medical school. I knew I wanted to be in the vascular space, and as a medical student, you're often involved at the workup of the patient, but also the bandaging and unbandaging of patients, and you learn a lot with taking care of wounds. And one of the most dramatic wounds that I've ever encountered was a poor patient who unfortunately did not have any family members, was kind of lost in a nursing home, and was unfurling his bandaging. And unfortunately, it was a necrotic black foot. And then I started to see maggots, and something started flying out of the wound. And the smell made your eyes absolutely just tear up. And that was the most dramatic. I mean, I was lost for words on how nobody directed him to any care. And so, I mean, you see these patients, and it's heartbreaking. It's like you just want to help them and provide them some element of relief. But that, to me, was the most jarring presentation of a PAD patient, no doubt.
Yeah, it's like, don't wait.
Yes.
Don't wait till I've had a patient just literally with goes to the doctor with a plastic bag and rubber bands around the leg. And it's like, well, why didn't you come sooner? Oh, I was waiting for my daughter and I didn't want to be a bother. No, go get help sooner. Leg pain, get help sooner. Um, Natalie, do you have a case where it could be a funny one, it could be a traumatic one, it could be whatever you I can tell you already you have a good one.
I think that we had one that was doing the moving and had such swollen legs, but thought that roller skating was going to be the answer and get the swelling down in the legs, which then resulted in a compound fracture on top of having to have revascularization. So we talk about making better decisions and not going over the top and really having those conversations about really taking care of it first before putting in your own thought process modality. Yes. So,
Well, thank you so much, Natalie Donnally and Mamdouh Khayat. Appreciate you. Clinic to community, the PAD awareness initiative of the year for 2025 through the Global PAD Association's Global PAD Impact Awards. Congratulations.
thanks so much, Kim. We appreciate it.
Take care, Kim. Thank you so much.